His only other medications are albuterol as needed. He had a mild allergic reaction to ampicillin as a child. He's in moderate distress. His temperature is fine, pulse is high, respiration high, BP low. Exam shows erythematous warm, then the rash on the right leg that is unchanged from yesterday. There is new raised pruritic lesion on the upper and lower extremity and trunk. Diffuse scatter and expiratory wheezes are heard, which is the diagnosis.
Okay, an anaphylactic, it's an anaphylactic reaction. An anaphylactic reaction is an hypersensitivity reaction to the exogenous factor, most commonly medications, food, or insect stings. It is mediated by activation of the IgE, which leads to the release of the histamine and other cytokines from the mast cells and basophils. These subsequently lead to acute inflammation and profound vasodilation in major organ systems, generally in the cardiovascular, respiratory, gastrointestinal, integ- integumentary system. Symptoms include the rapid onset of bronchospasm with dyspnea or wheezing, urticaria, flushing, nausea, and emesis, edematous lip and tongue, hypotension, tachycardia. When severe and untreated, it can progress to our circulatory collapse. It can progress to circulatory collapse with a cardiovascular arrest or death caused by asphyxiation and airway obstruction. Treatment includes the administration of epinephrine, antihistamine, bronchodilator, glucocorticoid, as well as IV fluid. Severe cases may require endotracheal intubation and administration of the vasopressor. Patients with a history of atopy and such as asthma, eczema, and a history of medication allergies are at increased risk for anaphylaxis. This patient has a history of ampicillin allergy, asthma, and eczema, and is presenting with the symptoms of urticaria, wheezing, tachycardia, and hypotension after initiating a new medication, making anaphylactic reaction the most likely diagnosis. Okay.
You read E.
Yes. Arterial vasculitis is a rare vasculitis of the small cutaneous vessel that presents with urticaria as well as a variety of the symptoms such as arthalgia, abdominal pain, proteinuria, hematuria, cough, hemoptysis, and uveitis. It is more prevalent in women and commonly occurs in the later in the life. It is less likely to cause this patient's urticaria than anaphylaxis. Okay.
Okay. Next. 37 men comes to the physician because he has had a two bowel movement containing bright red blood during the past 6 hours. He has a 3 day history of intermittent severe abdominal cramps and diarrhea. He had 5 loose stools daily during this period.
Okay, can you tell me like what are the feature can be found in cocaine toxicity?
In,
There is
in
striking.
cocaine,
Yes.
okay. Pupillary dilation,
Yes.
hypertension,
Mydriasis. Yes.
yeah, hypertension, tachycardia, fever. Um,
Tachy, hypertension. Yes.
is there fever or no? I'm just saying,
Not really.
really.
Uh, there
Um,
may be euphoria
euphoria, okay.
and there may be chest pain.
Oh, there's chest pain. Okay, yeah, chest
Okay,
pain
chest pain and seizures.
and seizures. Okay.
I told you because I need to remember this.
Oh, no, that's good. I have to remember too. Uh,
These PCP, LSD, cocaine, methamphetamine, these
oh,
are
those are-
so disturbing.
yeah, the abuse thing. Uh, some of them help, like with the party helps, like the opioid and the
Not
amphetamine.
always, as most of like most of the question we have solved like previous one to question back. There is cocaine intoxication, like question number 35.
Mm-hmm.
On that question, uh, there is people is dilated, but other features is like confusion, screaming loudly. There is history of major depressive disorder. Okay, there is presence of agitation. Okay,
Okay. Um, he has no history of serious illness, doesn't take medications. Last visit to the physician was 5 years ago. Most recent travel experience was a trip to Canada 6 months ago. Temperature is fine, pulse is fine, blood pressure fine. Abdominal exam shows diffuse severe tenderness with no peritoneal sign. Bowel sounds are increased. Rectal exam shows no abnormalities. There is no stool in the rectal vault. Um, okay. His hemoglobin concentration is, I guess that's fine. Leukocyte count is high. Platelet count is normal. Which of the following is the causal organism? Let me see. I'm not
in
looking at
this
it.
question, like close Cryptosporidium parvum, it causes watery diarrhea. E-tech causes watery diarrhea. The bloody one is EHAC, like E. coli 015787. Clostridium difficile cause pseudomembranous colitis, and Clostridium perfringens cause gas gangrene. So only organism causing bloody diarrhea, bright red streak. It is E. coli 015787. And there is another uh, EHAC, and EHAC is one form of H15. It can cause bloody diarrhea, and it can also cause hemolytic uremic syndrome. Okay. Mm,
Next, 50 men with 30-year history of paranoid schizophrenia is admitted to the psych facility because of exacerbation of his condition. His history includes multiple admissions to hospital for the condition. Physician prescribes oral antipsychotic therapy and the patient agrees to take the medication while in the facility, but he says that he does not need it and he will stop taking the medication as soon as he's discharged. He says, I don't trust any of you. You are all out to get me, but I'll play along until here is done. Which of the following is the most appropriate next step in management?
okay, change the oral antipsychotic therapy to the long acting. Okay. Non-adherence is a common challenge in patients with non-adherence is a common challenge in the patients with schizophrenia. Most patients, most antipsychotic agents are dosed with daily dosing, which creates a risk for undertreatment, relapse, and potential hospitalization or death in patients who self-discontinue the therapy. Long-acting antipsychotic provide a useful method of sustaining treatment and reducing relapse and hospitalization in patients with high risk for or known history of non-adherence. A variety of the dosing regimen may be used. Available long-acting injectable antipsychotics include both first-generation antipsychotics like haloperidol, atypical antipsychotic like aripiprazole, olanzapine, paliperidone, risperidone. The adverse effects profiles of long-acting injectables or antipsychotics are typically similar to their oral equivalents. Selection of Mm. Selection to long-acting injectables. Antipsychotics is based on history, prior treatment response, and medication adverse effect profile. Okay.
Unit A.
Yes. Administration of antipsychotic therapy until the patient's paranoia completely resolves is incorrect. This patient has known history of multiple hospitalization and remains at high risk of relapse following discharge from the hospital, even if his symptoms are well controlled at the time.
Next. 8-year-old boy brought to the ED because of 2-day history of urinary urgency, frequency, right-sided abdominal cramps. The cramps are intermittent and he cannot get comfortable in any position when they occur. He has had no fever, diarrhea, constipation, but he has vomited twice. He has no history of similar episodes or serious illness. He takes no medication. Paternal uncle has a history of renal kidney stones, and his cousin has Crohn's disease. The patient has no dietary restriction. Temperature is fine. Right flank is tended to palpation. Abdominal X-ray shows 3 millimeter ovoid opaque mass in the right pelvis. Lab shows urea high. Creatinine is normal. Wait, it's low, I guess. Urine pH is, I think that's fine. RBCs are a lot and white blood cells are a lot. In addition to administration of morphine, which of the following is the most appropriate next step managing?
Okay, so it is what is your diagnosis?
Is it a kidney stone or something?
Okay, where is fever?
Uh,
There,
oh,
oh, there is no fever, but it
it's
is
not really
kidney stone.
fever.
Yes, you are right.
Yeah.
But nephrolithiasis is a young patient, not fever. Very unlikely. Okay.
Mhm.
Nephrolithiasis or urolithiasis describes the formation of the calculi within the urinary collecting system, otherwise known as renal calculi or urethral stone. This typical presentation of renal calculi This typical presentation of the renal calculi that have become lodged in the ureter urolithiasis include severe intermittent sharp flank pain, severe intermittent sharp flank pain with either gross or microscopic hematuria leukocytosis and occasionally evidence of concomitant urinary tract infection. Calcium containing stone are the most calcium containing stone are the most common varieties, although renal calculi may also be composed of cystine, struvite, and uric acid. While abdominal plain X-ray were traditionally used for diagnosis, ureter stones are radiolucent, and given the availability and the sensitivity of advanced imaging, a non-contrast CT scan of the abdomen and the pelvis is now preferred imaging modality for definitive diagnosis. One exception that One exception to these in pediatrics were imaging modalities that involve less radiation, such as ultrasonography, such as ultrasonography and X-ray are often used before modalities such as CT. Acute management depends on the size and the location of the calculi, in addition to complicating factors such as abnormal anatomy or the concurrent presence of urinary tract infection. Calculi larger than 6 millimeter often require intervention. Calculi larger than 6 millimeter often require intervention as they are unlikely to pass off their own. For smaller calculi, a- in clinically stable patient, treatment with oral hydration and analgesia is appropriate.
Unit A. This one. I mean, maybe, yeah, this one.
So as this patient is clinically stable, because they haven't done the ultrasonogram, isn't it?
They haven't done.
Sorry, they have done
They
X-ray.
have done.
Sorry.
Mhm.
So it is 3 millimeter. If it is more than 6 millimeter or 6 millimeter, then it is unable to pass through the ureter. Okay, so after 6, so that's why. Okay, which number?
This one, the first answer,
Okay,
A.
A.
Mhm.
Oral administration of the allopurinol may be used. Oral administration of the allopurinol may be useful in the treatment of renal calculi composed of uric acid. Uric acid stones are typically radiolucent, uric lucent, and the patient's stone is radio opaque, suggesting suggesting a stone composed of either calcium oxalate, calcium phosphate, calcium oxalate, calcium phosphate, and ammonium magnesium phosphate. True white stone. Once administration of the potassium citrate is useful for urine alkalization, which increase the solubility of the uric acid and thereby preventing the uric acid stone formation from uric acid stone formation or aiding the dissolution of existing uric acid stone. Okay.
Okay, next. Previously healthy 57-year-old woman comes to the physician because 6 month history of muscle weakness and fatigue. The weakness began in the muscle of the face and have progressed to all the muscle in the body. Exam shows bilateral ptosis, weakness of the left abducens muscle. An X-ray of the chest shows mediastinal mass. Which of the following is the most appropriate next step in diagnosis of this patient? Neurologic findings.
So what is your diagnosis?
Mm, I guess myasthenia. I guess.
Why?
I don't know. I really was
There
not
is
doing
there is ptosis, bilateral ptosis. There is like this mediastinal mass is not the cancer like Eaton Lambert.
Oh, yeah, yeah, yeah,
Is
yeah.
not.
Oh, it's not?
Yes, because I am thinking if it is myasthenia, there may be thymoma, maybe one of the thing happens like can come with the mediastinal mass, like anterior mediastinal mass, the 4T. Can you remember?
Mm,
Like
yeah,
thymoma, terrible
thymoma.
lymphoma. So it
What was the
can,
other one?
sorry,
It was, what were the other ones? Thymoma, terrible lymphoma, what?
thymoma,
Okay, I
thyme,
forgot.
okay,
What was the other one?
thyroid, there may be thyroid neoplasm.
Okay, thyroid,
And there is another thing as
I
I
forgot.
can remember. Okay.
Yeah. Okay, so you don't think the mass in the thing is a thymoma?
Yes, it may be thymoma.
Okay, maybe thymoma.
So 6 months history, muscle weakness, fatigue, and there is bilateral ptosis because Eaton Lambert may not come with the ptosis.
Mm-hmm.
Eaton Lambert has a mass, like Eaton Lambert can come with the mass, but Eaton Lambert cannot come with the ptosis. Okay. So in myasthenia, we know the nerve conduction study. In myasthenia, like MD, decremental response in the nerve conduct study, and Eaton Lambert may be incremental response. Okay. So in myasthenia gravis is an autoimmune disorder of the neuromuscular transmission that has bimodal age onset peaking in both bimodal age onset peaking in both young adults and older adults. So it has bimodal age distribution like young adult and older adult patients with myasthenia gravis possess antibodies that block that block or destroy the nicotinic acetylcholine receptor, which interferes with the neuromuscular junction signaling. Many patients with myasthenia gravis have thymic hyperplasia or thymoma. In myasthenia gravis, the thymus, which is the site of T lymphocyte maturation, may show abnormality in the presentation of nicotinic acetylcholine receptor as an antigen to helper T lymphocyte. This abnormal antigen presentation is postulated to result in autoimmune attack of the nicotinic acetylcholine receptor on the skeletal muscle cell. Patients present with progressively worsening skeletal muscle weakness at rest, and fatigability on activation in focal or generalized muscle mass. Thus, nerve conduction study with repetitive stimulation used to confirm the diagnosis. The ocular, valvar, and the neck muscle are commonly affected. Most concerningly, a respiratory muscle weakness can lead to respiratory insufficiency in acute flare. These patients may require mechanical ventilation. Management include symptomatic treatments such as acetylcholinesterase inhibitor with immune modulating therapies. In patients with thymoma and complete thymectomy. eh, Complete thymectomy may be the curative. Okay.
Okay. Okay. 29 women gravid at one para one comes to the physician 1 week after noticing a mildly tender lump in her left breast. 5 months ago, she delivered a healthy newborn at term following an uncomplicated pregnancy and spontaneous vaginal delivery. She's breastfeeding and says her infant feeds equally from both breasts. The patient has no history of serious illness. Her only medication and prenatal mother diagnosed with breast cancer at 61. The patient vital signs are normal. Exam shows no axial reciprocavicular lymphadenopathy. There is 3 centimeters smooth mobile cystic tender mass in the upper outer quadrant of the left breast. Which of the following is the most appropriate next step?
Okay, there is 3 centimeter smooth mobile cystic tender mass in the upper quadrant. Okay, another confusing question. Okay, uh, a galactosile is a benign cyst of the mammary glands caused by the obstruction to the lactiferous duct flow. Given its location, it is filled with milk rather than clear fluid. They occur in lactating mother or woman who recently discontinued lactating and present with firm fluctuant mass that is painful, and a firm fluctuant mass that is painless or mildly tender, commonly located in the subareolar area. Vital signs within vital signs will be within normal limits. Diagnosis is typically clinical but can be based on fine needle aspiration, which would be most appropriate next step in the management of this patient. If obtained, ultrasonography, if obtained, ultrasonography would show a cystic mass. Ultrasonography would show a cystic mass. Galactosils generally resolve on their own, but can be aspirated or excised if they persist and are symptomatic. Complications are complication complication are uncommon, but include superimposed infection and abscess formation as well as rupture and subsequent formation. Why it is not like increase?
Last time.
Okay, look at the mm, option C and E. Discontinue breastfeeding or increasing breastfeeding of the left breast would not affect this patient's galactosile, which
Mhm.
commonly occurring in the lactating woman. Changes in the breastfeeding have not consistently been associated with improvement of the galactosile. Rather than the patient should undergo fine needle aspiration to confirm the diagnosis and improve her symptoms.
Next. Can you give me 1 minute?
Yes, yes.
Okay, I'll go right back. Vehicle collision at 35. There is no family history of serious illness. Pulse is fine. BP is fine. No jugular venous distension. Pulmonary exam shows no abnormalities. Diagram of cardiac auscultation is shown. The murmur does not change with inspiration. Position of Valsalva. ECG shows no abnormality. Which of the following is the most appropriate next?
Okay. So no management is indicated at this time.
I don't even know what murmur he has.
Sorry,
I don't even know what murmur he has.
he has like look. The murmur does not change with inspiration. The murmur does not change with positional or any sort of maneuver. It does not related to the inspiration or expiration. If
Mhm.
somebody has murmur 1 to 2 grade in murmur, does not changes with the position and inspiration, so maybe benign murmur, and benign murmur is mid systolic. This murmur looks like mid systolic.
Yes.
Maybe
Okay.
there is a difference like between benign and the malignant murmur. Do you remember like there was a box
Yeah,
in,
there was a box. Mhm.
okay. Okay, no management is indicated at this time for otherwise healthy 18-year-old patient with no apparent risk factor. Benign murmur are common in childhood or adolescence and do not require treatment. They also refer to as innocent murmur. They also refer to as innocent murmur result from normal blood flow, and the clinician should consider of serious the clinician should consider the possibility of serious cardiac disease as a murmur may be single presenting feature. Risk factor include family history of the cardiac factor, sudden cardiac death, exposure to teratogen. Both family history and sudden cardiac death goes with the HOCM. An exposure to teratogen in utero and a prior history of mucocutaneous lymph node syndrome like Kawasaki disease and rheumatic fever. On physical examination, there is holosystolic or diastolic murmur should prompt concern. Additionally, since benign murmur are normal blood flow, does they should decrease in intensity. They should decrease in intensity to the maneuver that decreases blood return to the heart, such as Valsalva. Valsalva through this is not always apparent in the clinical setting. Further workup is indicated if patient presents with vital sign abnormality and or significant symptoms, especially chest pain, syncope, palpitation, shortness of breath, poor exercise tolerance, and failure to thrive. Okay.
Okay. Next. 37-year-old woman brought to the ED 30 minutes after an episode of syncope at the shopping mall. She said she had a shortness of breath and was sweating before she passed out. She has childhood history of asthma. She currently has panic disorder and GERD. Current medication, sertraline, omeprazole, and OCPs. On arrival, she's alert and oriented to person, place, and time. Temperature is fine. Pulse is high. BP low. Pulse oximetry or room air shows 90. Examination, including neurological exam, is fine. Labs, hemoglobin, I guess, is a bit low. Leukocyte count is fine. pH is normal, or let me see. It is a bit basic. PCO2 is
Low,
low. P PO2 is low too.
low.
Which of the following is the most likely explanation of these findings? Let me see.
What is your
Hemoglobin,
diagnosis?
female 12. Okay, so everything is fine.
So this patient has like alkalosis, which is respiratory, isn't it?
Respiratory
Uh,
alkalosis. Okay,
yes,
okay, yeah.
respiratory alkalosis has like pulmonary embolism, respiratory alkalosis. There are other like hyperventilation can cause respiratory alkalosis, isn't it? Like hyperventilation syndrome,
Mm-hmm.
pulmonary embolism, panic attack, and this patient has hypotension, tachycardia, tachypnea, and history of OCP. Looks like
Mm-hmm.
PE.
Mm-hmm.
Okay,
Mm-hmm.
so this patient's presentation. This presentation finding concerning of acute pulmonary embolism, it classically presents with chest pain, shortness of breath, and hypoxemia. Sometimes patients may also experience unexplained syncope. It is often difficult to distinguish PE from other acute respiratory disorder. The differential includes asthma exacerbation, vocal cord dysfunction, ACS, panic attack, vasovagal syncope. The clinician must maintain a the clinician must maintain a high index suspicion. The use of clinical decision aids such as Wells score, risk factor for acute PE include immobility, obesity, recent surgery, malignancy, pregnancy, use of OCP, trauma, fracture of the long bone, inherited thrombophilia, fracture of the long bone, inherited thrombophilia. ECG often displays normal sinus rhythm or sinus tachycardia. ECG sometimes normal sinus rhythm and sinus tachycardia. ABG most typically show acute respiratory alkalosis, hypoxemia, and increased AA gradient caused by ventilation perfusion mismatch. CT pulmonary angiogram is preferred method to confirm the diagnosis. This patient may be experiencing a massive pulmonary embolism given tachycardia, borderline hypotension. She should be treated with anticoagulant and also potentially thrombolytics. Okay.
Okay. Yeah. Next, 62 woman comes to the physician because 2 month history of generalized fatigue and mild low back pain. Mm. She has not had any of those symptoms. She has no history of serious illness, doesn't take medication. Her last health Mendes exam was 10 months ago, and CBC at that time was within range. Examination shows no abnormality. Labs, hematocrit, believe is low. MCV is high. Let me double check. Hematocrit is low. MCV high. Leukocyte count normal. Segmented neutrophils high. Bands normal. Lymphocytes. Am I reading it right? Yeah. Lymphocytes normal, platelet count normal, calcium, creatinine is high, calcium is high. A blood smear is shown. Which of the following is the most appropriate next step to confirm my diagnosis?
What is your diagnosis?
The multiple myeloma.
Okay. So it is multiple myeloma. You need you want me to read the explanation?
Oh yeah.
Okay. These patients presenting findings of bone pain, anemia, hypercalcemia, and renal dysfunction are consistent with the diagnosis of the multiple myeloma. Multiple myeloma is a malignancy. Multiple myeloma is a malignancy caused by neoplastic proliferation of the plasma cell, uh, neoplastic plasma cell uh, overproduce a monoclonal neoplastic plasma cell overproduce a monoclonal immunoglobulin light or heavy chain, which may result in acute renal failure. Patients commonly present with constitutional symptoms, fatigue, weight loss, lytic bone lesion, hepatosplenomegaly, symptoms of hypercalcemia, kidney stone, and psychiatric disturbance, symptoms of anemia, pallor, lightheadedness, dyspnea on exertion, or with opportunistic infection secondary to immune dysfunction. Further workup is recommended with a complete blood count, complete metabolic panel, urinalysis, urine and serum protein electrophoresis, and imaging to determine the extent of the malignancy. Peripheral blood smear classically discloses red blood cell aggregation in a rouleau formation. The diagnosis is confirmed by bone marrow biopsy. Okay.
What was the mnemonic again here?
Crab.
Braf?
Yes, CRAB.
Crab. It
Yes.
was calcemia,
Renal
uh,
failure,
anemia, and
anemia, and bone pain, lytic lesion in the bone. Okay. Suppose you find a patient with isolated ALP high ALP,
mm-hmm.
like ALP is near about 1500,
Okay.
and there is a history of in the childhood he has a history of retinoblastoma. For this retinoblastoma,
Mm-hmm.
he had done like enucleation.
Mm-hmm.
So what is your answer then?
Mm, osteosarcoma.
Yes, osteosarcoma. That is osteosarcoma.
Mm, okay. 37
And
men.
and another thing, like in as a complication, like in Paget's disease
Mm-hmm.
of the bone, as a
Mm-hmm.
complication, osteosarcoma can come.
Yeah. Mm-hmm.
Yes, and the another complication of Paget's disease of bone is, apart from osteosarcoma, there is another complication.
Oh, the high acute heart failure.
Yes, high outflow. Okay.
Oh, you are ready for the exam.
No, no, I am.
You are definitely ready.
I am reading those things.
like, like every single little thing, like you like remember. Like, oh,
I am trying to recall what I am learning.
okay.
Nobody is ready for any exam, and you don't know how much
How much?
drowsy I am.
But I read the reviews for the last week score report. They were good. A lot of people passed, so it's good. I mean that means it's not super hard. Okay.
It is for
The-
people.
But
Examination for pa- varies from person to person.
I don't. I feel like the people that fell don't also come and comment. Like not that many comment say, "Oh, I didn't do good." So that's
The
maybe.
very few people actually comment. The
Yeah,
people who are super in the exam, they actually comment,
they
and
actually coming. Yeah.
lots of people actually keep themselves under the ice. Okay.
37-year-old man comes to physician for routine health. He feels well. He has no history of serious illness. Doesn't take medication. He received Hep B vaccine at 28. He does not smoke or drink alcohol during the past 6 months. He has been sexually active with one male partner and they do not use condoms. Patient works as an accountant and has not traveled outside of the US. Exam shows no abnormality. Blood sample is obtained for serum lipid studies and HIV antibody tests. In addition to counseling this patient about risk factors for STDs, which of the following is the most appropriate next step in management?
Okay, it is hepatitis A vaccine. Hepatitis A vaccine is a non-enveloped single-strand. Hepatitis A vaccine is non-enveloped single-stranded RNA virus that is spread through fecal transmission. It is common yet preventable cause of liver disease. It is commonly acquired through ingestion of the poorly cooked and improperly handled raw food. Presenting symptoms include nausea, vomiting, poor appetite, abdominal pain, jaundice, hepatomegaly. Although many patients are asymptomatic, lab findings include transaminitis increase the risk of ALP, hyperbilirubinemia, bilirubinuria. Liver biopsy is not routinely acquired but may show ballooning hepatocyte degeneration and councilment bodies. Outbreaks of hepatitis A virus are common. Outbreaks of hepatitis A virus are common among men who have sex with men. The Centers of the Disease Control Advisory Committee on Immunization Practice recommends a routine vaccination against hepatitis A virus MSM patients as well as high-risk population including international travelers and high risk areas. HIV patients experience homeless and users of injection drug. The hepatitis A vaccine is inactivated vaccine as given intravascular injection in a series of 2 injections. Okay, what is the clue here? He has not traveled outside the USA.
Oh, the clue is that he's having sex with another man. He says he's been sexually active with one male partner. He's a man and he's having sex with another man. And they're saying that Hep A is increasing men who have sex with other men.
Very unusual.
Very, yeah. That's why I
I,
went to
I,
sketch.
I, I am unable to match. Like, in where is the hippo doing? Is there anything written about men?
No, that's why I went to look. I was like, I don't remember that, but no, I guess it's something new. I mean, not, it's nothing sketchy. No, it's not. Hmm. Yeah, no, it's not here. I guess something just to remember, put in the back of your head. Yeah.
The
Okay.
back will break. If
The
we,
back with it's like divine intervent, divine guide. He's like everything, put it in the back of the head, put it in the, and I'm like the back of my head is getting so big, it's like doesn't even make sense anymore. But yeah, okay. 27-year-old man comes to the physician because of a 1 month history of sudden episodes of scary, choky feeling. He has had 3 episodes during this period. The episodes are accompanied by nausea, swelling, and heart pounding sensation. The symptoms peak within 5 to 10 minutes and disappear about 15 minutes later. The first two episodes came out of the blue while he was at work. The last episode occurred when he was stuck in traffic. He is fearful that he will have another episode and that someone will notice and think he's crazy. He has no history of medical illness, no medication. He's a veteran of the Marine Corps and experienced some intense fighting 5 years ago. He has occasional nightmares involving combat and intermittent sadness when he thinks about his military friends who were killed. He has occasional difficulty falling asleep. He has had no change in energy level or appetite. BMI is fine, vitals are normal, physical exam is fine, mental status exam, he's anxious but relates well with physician. Serum TSH is fine, ECG normal, a most appropriate pharmacotherapy.
Choking feeling like all the features of panic.
Mm-hmm.
Palpitation, P for palpitation, A for remember recently I have studied. Okay. Palpitation, choking, heart pounding. These are all the features of panic disorders. And panic, we can give SSRI and paroxetine can be given. Okay. Okay.
Okay.
I am
You want
reading.
to read?
Okay.
Oh,
I
okay.
am reading the explanation. Okay.
Mm-hmm.
So in panic disorder features, panic disorder features, panic attacks that occur unexpectedly and are associated with changes in behavior to avoid panic triggers. Panic attack feature acute fear or anxiety that peaks within minutes and is associated with four additional physical symptoms. Mental status. These additional symptoms may include heart palpitation, tachycardia, shortness of breath, chest pain, dizziness, the sensation of choking, GI distress, paresthesia, sweating, trembling, derealization, fear of dying, fear of losing control. In patients with initial episodes of panic symptoms, a thorough history and physical examination, along with the basic lab workup and a potential ECG, should be performed. Panic disorder can be distinguished from post-traumatic stress disorder by the presence of several characteristic features such as re-experiencing the initial traumatic event, symptoms of being triggered by reminders of the traumatic event hyperarousal, such as increased vigilance or exaggerated startle response, and negative symptoms such as depressed mood, loss of interest, or difficulty concentrating. Treatment of panic disorder typically includes psychotherapy, SSRI, such as paroxetine, short-term benzodiazepine. Other classes of medication that may be occurred for treating panic disorder include monoamine oxidase inhibitor and tricyclic antidepressant. Okay.
Next. Previously healthy 25-year-old man brought to the ED 2 hours after being involved in the motor accident. He was the restrained driver. On arrival, he's alert to and oriented to everything. He says he has severe lower abdominal pain. Temperature is fine, pulse is high, respiration normal, blood pressure normal. Abdominal exam shows ecchymosis over the lower quadrant and an abrasion where the seatbelt was fastened. There is suprapubic tenderness. Palpation of the iliac crest produces the pain. There is blood at the ureter meatus. Hematocrit is low. X-ray of the pelvis shows a fracture of the superior and inferior right pubic rami and the right sacroiliac joint. Okay. Which of the following is the most appropriate next step management?
Okay. Blood at the urethral meatus following trauma. Blood at the urethral meatus following trauma raises concern for urethral injury. Urethral injuries are characterized by difficulty avoiding blood at urethral meatus, perineal ecchymosis, and may be associated with pelvic fracture. Straddle injuries can cause trauma to the anterior urethra, while pelvic fracture may injure posterior urethra. Pelvic fracture, posterior urethra, straddle anterior urethra. Urethral injuries are evaluated with urethral injury are evaluated with retrograde urethroskopy, which involves the injection of the contrast into the urethra to evaluate for the extravasation of contrast, indicating urethral discontinuity. Depending on the location and the severity of the urethral injury, patients may require surgical repair or placement of urethral catheter to help promote healing and prevent complication of urinary extravasation, infection, urethrocuteneous fistula, or urethral stricture. And
Can you read? I'm sorry.
yes, A option A,
A, C, and D.
yes. Cystography is indicated in evaluation of the urinary. Cystography is indicated for evaluation of the urinary bladder when bladder injury is suspected. So bladder B for cystography. These allow characterization. This allows characterization of an intraperitoneal versus extraperitoneal bladder rupture, which dictates the next step in the management. Placement of suprapubic catheter may be necessary, but first delineation of the injury location and pattern should also occur. An indwelling urethral catheter is less invasive than suprapubic catheter and is preferred if insertion would not exacerbate trauma. And IV pylography involves the intravenous injection of radio-opaque contrast to subsequently visualize the kidney, ureter, bladder under fluoroscopy. This allows for investigation of suspected urinary tract anomalies, malignancies, and stricture.
Okay.
Okay.
Next. 47. Oh, section 2. 47 woman comes to physician because of a 3-week history of moderate pain in her arms and legs. She stated that her bones ache in all joints, both at rest and with movement. She has history of hypertension, hyperlipidemia, diabetes, controlled with mirror medication, thiazide, statin. Her sister has Sjogren and her mother has coronary artery disease. She doesn't smoke and doesn't drink that much. BP is high, cardiopulmonary exam is fine. There is tenderness to palpation over the wrist, metatarsophalangeal joint, knee, and ankle joint. Cupping of the fingers and toes are noted. Chest X-ray shows a left upper lobe mass with perihilar lymphadenopathy. X-ray of the tibia and fibula shows periostosis. I don't know what periostosis means. Which of the following is the most likely diagnosis?
What is your diagnosis?
The hypertrophic pulmonary
Yes, it's
osteopathy.
a hypertrophic pulmonary osteoarthropathy. Hypertrophic osteoarthropathy is a syndrome. Hypertrophic osteoarthropathy is a syndrome caused by abnormal fibrovascular proliferation, and is characterized by triad digital clubbing, periostosis, inflammation of the periosteum, particularly in the long bones, and severe arthalgia. digital clubbing, periostosis, and severe arthralgia. It may be caused by rare congenital condition, but most cases secondary to a non-congenital condition of these pulmonary pathology is most common cause. The pathophysiology is associated with hypoxemia related changes in the growth systemic growth regulation. Other causes include primary cardiac, GI, or hepatic disease, as well as lymphadenopathy makes secondary hyperosteoarthropathy as a result of pulmonary malignancy the most likely diagnosis. Okay.
Okay. Next. Healthy 16-year-old girl comes to the physician for school physical exam. She's sexually active with one partner and does not use contraception. She has smoked a pack of cigarettes steady for 2 years. She is 5'4". BMI is fine. Physical exam fine. Which of the following behavioral modification is most likely to have a greatest impact on mortality in this patient during the next 10 years?
Never heard about this.
Hmm.
Okay, seatbelt use. Okay, the most common the most common cause of death in teens and young adults is accidental death, and frequently in relation to fatal motor vehicle collision. This is followed by homicide, suicide, malignancy, and heart disease. This patient has this patient has several factors that are likely to lead to adverse health outcomes, such as being overweight, using tobacco, having an unprotected intercourse. Being overweight increases the likelihood of the diabetes, hypertension, hyperlipidemia, heart disease, while tobacco can increase the likelihood of a cancer after years. Unprotected sexual intercourse can STD and untreated pregnancy, while uncomplicated pregnancy can lead to death. Uncomplicated, it is most less common the accidental death in young adults. Thus, the behavioral modification that is most likely to have greatest impact on this patient's mortality during the next 10 years is increasing the seatbelt use. This is uncommon. Okay.
Hmm. Next. 82 woman who resides in a nursing facility is transferred to the hospital because of 2-day history of fever and cellulitis. Okay, of the left side of the face. She's hemiparectic, aphasic, unable to swallow. She's fed through a gastrostomy tube. She has congestive heart failure, diabetes, hypertension, hyperlipidemia, depression, she just has everything. Medications: furosemide, metoprolol, digoxin, glyburide, lisinopril, statin, amitriptyline, alendronate, aspirin. She appears ill and moans frequently. Temperature high, pulse is normal, respiration high, BP is a bit low. Firm, exquisitely tender mass is palpated from her left cheek to the angle of the mandible. This area is also red and edematous. The left pinna appears normal and the aortic canal is fine. Mouth is dry. Bilateral basilar crackers are her. Cardiac exam is fine. The abdomen is soft, fine. The gastrostomy tube is in place with no inflammation. Leukocyte count is high. Segmented neutrophil, I believe, is high. Band is high. Lymphocytes low. And serum glucose concentration is high. Chest S ratio, cardiomegaly. There are bilateral basilar increased markings and atelectasis of the left lung, but no focal infiltrates. Which of the following is the cause of the patient fever? She has everything. I don't know. Pneumonia.
Okay. One by one. Osteonecrosis is jaw done by which thing.
There is phosphonates.
Yes. So it is not, there is no hist. Okay, he is using alendronate actually.
Mhm.
So it is not, may not be, it is osteonecrosis of the jaw because there is inflammation, leukocyte count is high. This is not the features of the necrosis. And we maybe we may be confused between A and C. It is not aspiration pneumonia, though is in the, because lungs, there are some bilateral increased marking and atelectasis in the left lung, but if it is aspiration pneumonia, then like in up, there is a word like in the lower lobe and the lower part of the upper lobe, like that this kind of thing happens in
Infiltrate.
aspiration. Sorry.
Mhm. Infiltrate
Yes,
in the lung.
infiltrate.
Mhm.
So it is, maybe it is acute suppurative parotitis. So facial swelling, erythema, and edema at the angle of the mandible, accompanied by fever, raises suspicion of acute suppurative parotitis. Acute parotitis is most often caused by mixed oral flora, Staph aureus. Risk factor for the development of parotitis include being elderly, dehydration, poor dentition, lack of salivary flow, debilation. In addition, the parotid duct can be obstructed by calculi or tumor, which can predispose patients to infection. The diagnosis is clinical and imaging with an ultrasound or CT scan can further evaluate for the presence of complications such as abscess formation or tumor. Imaging can also delineate involve structure when the diagnosis is unclear or differential remains mixed. Management of acute suppurative parotitis involves administration of the IV antibiotic and monitoring to evaluate for clinical improvement. Okay.
Can you read C?
Yes. Mandibular osteomyelitis can cause jaw pain. It's typically non-suppurative, does not usually cause erythema and swelling unless severe and rapidly broken. The diagnosis can be excluded on the clinical picture alone in this case, but is less likely.
Mm, okay. 42 hospitalized 42-year-old man has chills and fever 1 hour after transfusion of packed red blood cells for treatment of anemia secondary to bleeding duodenal ulcer. He has never received blood transfusion in the past. He has no known allergies. He's pale and flushed. Okay. BMI is fine. His pulse is fine, regular, BP fine, exam shows no abnormality. The most appropriate next step in management is administration of what?
Okay. Febrile or non-hemolytic transfusion reaction are caused by the release of cytokines from the leukocytes during blood product storage and uh, are a common transfusion reaction. It presents during shortly after transfusion with an isolated fever and possible rigors without other systemic symptoms. Lab and radiographic evaluation are unremarkable. Risk factors include administration of platelet and red blood cells, especially in children, and long storage time of the blood product. Pre-storage leukoradiation and the removal of the leukocyte from the blood product decrease the risk for development by decreasing the extent of the cytokine release. Treatment includes stopping the transfusion, treating the fever, evaluating for the cause of the fever. Therefore, in this patient, isolated fever following a blood transfusion, isolated fever following a blood transfusion, antipyretic treatment with oral acetaminophen is the most appropriate next step in the management.
Okay. Next. 77 woman comes to office because of a 1 year history of frequent urinary incontinence during the day and night. The incontinence is not associated with coughing and sneezing, and she does not have urinary urgency, so it's not urge, it's not stress. She has not had pain with urination or vaginal discharge, so no UTI. She has a 10-year history of type 2 diabetes, well controlled with metformin. Her other medication, atorvastatin, is in effect. Examination shows some wetting of an absorbent pad that she's wearing. Results. Um, mm, 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 mm. Oh, I don't think we need the results on here, but okay. Sodium is fine. Sodium is fine. Potassium fine. Chloride fine. Bicarb fine. Glucose a bit high is high. Creatinine normal. Urine pH is normal. Glucose 1 plus. Protein 2 plus. RBC none. White blood cell. Guess. Yeah. Cas none. Which of the following is the cause of the incontinence?
So it is neurogenic bladder, autonomic neuropathy is common in patients with both type 1 and type 2 diabetes. Autonomic neuropathy is common in patients with both type 1 and type 2 diabetes mellitus. Autonomic neuropathy may occur independently or accompanying peripheral sensory neuropathy. Autonomic neuropathy may present with cardiovascular manifestation of exercise intolerance, orthostasis, GI manifestations such as gastrointestinal, gastroesophageal reflux, gastroparesis, diarrhea, genitourinary manifestations such as neurogenic bladder or erectile dysfunction. Neurogenic bladder results in impaired autonomic sensation of the bladder filling with subsequent overflow or neurogenic pattern of the incontinence. Overflow incontinence results from urinary retention, which is evidenced by increased PVR when the intravesical hydrostatic pressure eventually overwhelms internal and external sphincter pressure. This patient will demonstrate passive leakage of urine and patient presents with incomplete bladder emptying with a weak urine stream.
You read A and C.
Yes, hyperglycemia may lead to polyuria in the setting of the diabetes mellitus, while polyuria commonly causes urinary frequency and urgency. It does not cause incontinence. Medication adverse effect do not cause incontinence. So no, nothing called incontinence apart from diabetes. Okay, can we
Okay.
stop here?
Yes, we can.
Okay,
I will see you tomorrow.
okay. You are very tired too.
Yeah, I am. Okay.
Bye bye.
See you.